But within the African continent, it is still a toddler in some areas, a teenager in others. But what has assisted is the formation of the African Federation for Emergency Medicine. It has helped societies get emergency medicine registered as and recognized as a base specialty. It is formed up by numerous national societies, and Srinath noted the importance of national societies in getting emergency medicine registered with authorities. But you can see across the African continent, those are the number of sites that there are now emergency physicians in place. And it's growing on a daily basis. What we're also seeing across the African continent is the sharing of resources. And these are not only from a financial perspective, but also from an intellectual one, where we are able to ensure that people have got a good training base, and residents are moved all over the continent in order to ensure that occurs. And then once they have been trained, they are assisted in the setup of more formalized systems in their base countries. And so there is hope. But whilst we are driving the development of emergency medicine in the African continent, we need to ensure that we are able to survive. We need to stand up for ourselves. And certainly we are not doing the greatest job in my neck of the woods. And so my last slide is just to say we need to keep calm and carry on, but perhaps not that calm. Emergency medicine thrives on the excitement, on the difficulty. We shouldn't shy away from it, but we also need to ensure that it doesn't damage us in the long run. We are not alone. We are not alone in South Africa. We are not alone on the African continent. Emergency medicine is a global force. And it's together that we are able to move forward. And it's together that we can survive any crisis across the world. And it's meetings like these that emphasize that. I apologize that the sound isn't coming through, but it is one of my favorite quotations from Winston Churchill, who said, "This is not the end. It's not even the beginning of the end. It is perhaps the end of the beginning." Thank you.
Next is Dr. Paul Kibela from the United States.
Next page.
Okay, perfect.
Next page. Later.
Okay. Well, thank you very much. You know, I'm giving a report on the Americas, and I'm going to be more heavily influenced on what's happening in the United States. One of the things that's happened through the Americas, as I understand, the volume in Canada after the pandemic is actually up. The volume, the volume in Mexico is up, and overcrowding is a problem in every country. But as Dr. Dickerson has said and pointed out, you know, the African emergency medicine organizations are about 20 years old. In the US, we turned 50 a couple of years ago. And so we're reaching some unique problems that I think all emergency medicine organizations, whatever their age, need to address. And these are some of the issues that we face in the US. which will be very different than some of the issues that face elsewhere. So I'm going to concentrate not on the same issues of overcrowding, but really what's happening in the U.S. and this is concern to the emergency physicians there. The biggest issue that we have in the U.S. right now is a workforce issue. For many, many years, we wanted to train more emergency physicians. We projected that there was going to be surplus, or there's going to not be enough emergency physicians in the United States. But unfortunately now, we probably have trained too many emergency physicians. And so we are looking at potentially in 8 years, in 2030, to actually have a surplus of emergency physicians. But the issue that's happening here is that no one, of course, saw the pandemic. But in the United States, emergency department volumes had gone up virtually every single year. And now when the pandemic hit, volumes obviously went down dramatically, up to 40% decreases during the pandemic. The issue that we have in the US is those volumes are still not necessarily back to 100%. And many, many people believe that we've plateaued in our volume of emergency department visits. I'm not so sure that's the case, but urgent cares have popped up, and telemedicine in the United States is becoming very, very prevalent. And insurance companies in the US, which is not an issue to much of the rest of the world, have scared patients from going to the emergency department, saying they're going to get a big bill, that was going to bankrupt them. So they're actually afraid to receive care. As I mentioned, there's these alternative delivery places. Telemedicine is taking off in the United States. It's amazing how many people will talk to their doctor on their phone now, rather than coming to the emergency department. You know, ED volumes are close, but again, our patients are much sicker than they ever were. The other thing that's happened in the US is that we are always in the US, there's somebody trying to make things less expensive. And so oftentimes in some emergency departments, doctors are being replaced by what are called physician assistants. Whereas instead of receiving 4 years of college, 4 years of med school, and 3 to 4 years of residency or 12 years of training, these people receive 2 years of training, or 3 years of training, or 4 years of training. And so they're lesser skilled people replacing emergency physicians because they cost less money. And that is a big concern to many of our emergency physician graduates. Emergency medicine, again, as we came up through youth, we became one of the most popular specialties in the United States. We were well respected, and a lot of people wanted to go into emergency medicine. And hence, a lot of programs started popping up. And so the number of residents that we were graduating 10 years ago to today, it's almost doubled in the last 10 years. So now, perhaps we are training too many emergency physicians, which is a serious potential problem in the United States. The big question here is what's the need going to be? Are our estimates correct? What we've seen during the pandemic is a lot of emergency physicians basically quitting, saying, I'm not going to do this anymore. So perhaps we are going to have attrition, as Dr. Dickerson warned us about, that people are getting burned out and they don't want to go back to do their job. But this, again, is something that we're watching very closely. One of the biggest issues that's affect the United States has nothing to do with emergency physicians itself. It has to do with our nurses. Our nurses quit in huge numbers during the pandemic. And so now the reason that we have so much overcrowding is we don't have anywhere to send them after the emergency department. There are no beds in the hospital, or if there are beds, there's no nurses to staff those beds. So patients that are admitted are backing up our emergency departments. We have the capacity now in our emergency departments to see the patients if we could just get the patients out of the emergency department. Oftentimes, 2/3 of our beds and our hallways are occupied with patients needing to be admitted to the hospital, but there's nowhere for them to go. Another issue that's happening in the United States is the way that the U.S. payment system works for hospitals. It's now bankrupting the majority of the hospitals in the United States. So we're going to be looking for some type of healthcare reform here to make sure that our hospitals stay open. Right now, almost half the hospitals in the United States are losing money. And this is a dramatic change from 4 years ago. So they started right prior to the pandemic, but during the pandemic it made it worse, but there was bailout money and monies to fund that. But now as COVID is over, the realities of the payment process are coming into place, and a lot of hospitals are at risk of closing. And certainly one of the issues is our graduates want to work in urban and suburban areas. They don't want to work in rural areas. And many of the rural areas, even if they wanted to work there, don't have the payment methodology to support an emergency physician. It's hard for probably many of you to realize, but many of our emergency medicine graduates, when they graduate residency, owe about 500,000 euros in tuition money. 500,000 euros or 500,000 US dollars is a lot of money to owe. And so oftentimes they can't get a job to support that. Sometimes it takes them 20 to 30 years to pay that money back, which is a problem. As Dr. Dickerson said, emergency physician well-being now is at an all-time low. The pandemic made burnout not just a problem, but a crisis. Many of our graduates are so stressed they have a hard time coming to work or functioning the way they used to function. This is something that we really need to work on, and I'll talk about some of the solutions that we are working on as we go forward, that many of you may be able to take to your countries and employ, so that you don't reach the crisis that we are reaching in the United States. The one thing that I think is important is to make firm estimates of how many emergency physicians and how many emergency providers your country needs. And where are they needed? Are they needed in urban areas? Are they needed in rural? And do you need to concentrate? Because the practice in an urban setting is very different than the practice in a rural setting. And are they trained the right way? Do they understand the technology that's needed? One of the biggest issues that we are working on here in the United States is to credential emergency departments, that not all emergency departments are equal, that there needs to be certain standards in the emergency department for it to be a high level, like a grade A, whereas something might be a grade B or a grade C or lower, or a 5-star, 4-star, 3-star methodology. But we are looking right now to certify to make sure that a 5-star emergency department is something where the doctors and the nurses feel safe, that they have the equipment they need, they have the nursing and support staff, that they have they enjoy their work there. Those are things that I think are important, that I encourage many of you to look at, is how to certify your emergency departments. And as Dr. Dickerson said, is where are these patients, or where are these physicians going to go? If they get tired of working in the emergency department, what is their next plan? What is their plan B? Can they work in an urgent care? Can they work doing telemedicine? Can they go into hospital administration? Can they do something where they still enjoy practicing medicine, but maybe not in the emergency department? In the U.S., we're looking at other options for how and where emergency physicians can practice. We're also looking for alternatives to nurses. Can we provide additional support staff in the emergency department besides nurses? Are there some type of assistant that the physicians can get that will make their job a little bit easier and help them do the jobs that doesn't require a physician? Can there be scribes or people that fill out your chart for you? Can they get your information for you, set things up for you so it doesn't require the emergency physician to do those jobs? And again, to continue to figure out what are the items that are currently stressing the emergency physicians and how do we correct them? One of the things that I have said throughout my time as being in leadership in emergency medicine is emergency medicine is not a place, it's a specialty. I believe in the future that there will be less emergency departments in the United States, or at least certainly less hospitals. The question is how can you access that emergency physician and the emergency physician mindset? Can we do it via telemedicine? Can we do it mobile? Can we do it in urgent cares or very small standalone emergency departments that don't have a whole hospital behind them? Can we manage more of our patients at home? If our problem is admitting them to the hospital, can we send more of them home and monitor them in some way? I do believe that emergency medicine still does have a bright future, as Dr. Dickerson said. I think the pandemic and the armed conflicts, not just in some parts of the world, but in every emergency department that we've all seen increased violence, that emergency medicine is the essential specialty of 2022 and beyond. And hopefully this will translate well, that we are the masters of the undifferentiated patient. And when I say undifferentiated patient, that's the patient that comes in with chest pain, or shortness of breath, or a headache that we don't know, it could be any diagnosis. We are the masters of anyone, anytime, soon any place, and the masters of doing more with less resources, less time, and less information. As I said, few have seen the challenges of the pandemic and the armed conflicts that we have, but we were there central in managing the front lines of the viral pandemic and still with traumas when nobody else really wants to do that job or is able to. And we managed not just injuries and illnesses, but we also hold patients' hands and comfort families in their greatest need. In my opinion, emergency medicine is still the greatest specialty, and I look to all of you to help solve some of these problems that have been created over the time, probably some by my generation, but I believe the future of emergency medicine is bright in the US, in Turkey, and throughout the world. Thank you very much.
Thank you. Next is Dr. Eric Review from France. I think Eric is doing his lecture through Zoom, so.
Hello, everyone. It's a great pleasure to see you. I'm very terribly sorry not being with you because I have a lot of friends in Turkey, Roger, Paul Kivela, and it's a shame I won't be with you. One of the things is you discuss about a lot of things about the problem that we are facing, so we'll try to exchange. Can you see my slides now?
Yes, we can, Eric, thanks.
Okay, thank you. So let's take an overview of the situation about in Europe, not only in France, but in Europe. One other thing is, so I'm regretting not being with you because we have some friends, and emergency medicine is also that it's more than friendship, it's sharing experience and sharing a lot of things we have in common. So the situation in Europe, as we do have a rising number of ED visits for the past 20 years, and the situation is still changing, and we'll see how it could be changed. So we'll make a small tour of Europe, and through a questionnaire that can be made about the situation in Europe. You want to know how is the emergency department? Ask to the nurse, ask to the patient. In this study, we asked to the European nurse how they can rate their own hospital and their own departments. And in these departments and these in Europe, nurses said that the quality of care is really low in Ireland, it's really terrible in Greece, and it's different in Switzerland. They have the feeling that they treat quite well patients, and as you see, the burnout situation is quite high, not in the Netherlands but more in the Greece. The job dissatisfaction is really high in Greece, so they want to leave, and mainly nurses want to leave. And as Paul Kivela said, it's exactly the same situation after the COVID. So we have less than 1/3 of US nurses want to quit their job. It's exactly the same in France and mainly in a lot of countries in Europe. If we compare in this study the situation in Europe and in US, it's exactly the same situation where the job dissatisfaction is really quite high now and is very similar Europe to US. So we don't have a lot of difference about that. And when you focus on Europe, it's really a poor quality of care that globally that comes through from the nurses, and the situation of burnout and job dissatisfaction is quite high. When you compare to, as Paul Kivela said, it's exactly the same, and we are facing this situation now everywhere. When you look in detail for some European countries, as you see, the worst situation for now is still in Greece, and we have a lot of colleagues from Greece just telling us that it's really terrible. They have a lack of nurses, lack of beds, job dissatisfaction, and a lot of doctors, they want to leave. As you see, it's quite similar in different countries in Europe. We don't have all the countries, of course, but it is really terrible that we are facing. Situation is better in the north of Europe, in Finland, for instance, and why not in Switzerland? But that's globally just the exception that we are seeing. If you ask the patient trusts our hospital, patient trusts our emergency department, but they are still coming to the emergency department. And patient just when we ask them to rate the hospital, it's exactly the same analyze that the nurses. They are very low, they trust, and they don't trust in Spain. They are quite, they trust the hospital in Finland, and they will recommend the hospital. They won't recommend the hospital in some country. They recommend in Switzerland. They don't want to recommend their hospital in Greece. So as you see, patients and nurses are saying exactly the same. They are quite focused quality care, and the patient satisfaction is really quite low everywhere. So there are a few differences between, to summarize, between the countries. But we see that even when you pay much more nurses, it's not enough to change the situation. Ireland and Finland report the high level of quality, but the national level are really different from a country for place to place. As when you see from USA, they have a fewer nurses per capita when you compare to European country, but the more nurses are not the same per patient in hospital. So we have to have some difference between Europe and US, but it's really quite similar. And one of the things I remember, I gave a lecture 2 years ago in Turkey. We are in the day after the COVID. And as Paul Kivela said, it's exactly the same situation. It's really terrible because we are missing more than 20% of nurses in our hospital now. 20% of nurses, it's exactly the same number of beds we are lacking. So we are closing our departments everywhere in the hospital because the lack of nurses, we need nurses. And it was due the day after, I could say day after, we are 2 years after the COVID, and it is the terrible situation. We had a congress a few weeks ago in Berlin with the USM that was exactly the same situation in all over Europe. When you look at the old data about the situation, number of physicians, not a problem of number of physicians. I'm quite glad to see that they have a huge number of physicians in US. It's not the point in Europe because a lot of emergency departments don't have enough emergency physicians. So we are trying to find other specialty could work inside the emergency department. It could be family doctors, it could be internal medicine, it could be geriatrics. It's one of the main concerns that we should have in our emergency departments. And the second problem we are facing in Europe is the aging population. And the aging population, as you see, is quite different from place to place in Europe, but it will be a tsunami that we will face in the next 10 years. So the aging population will come more and more. And the situation is really quite worrying in Germany, for instance, because they have a high level of geriatric in the emergency department, but exactly the same in Spain, in France, in Italy, that we have a lot of patients of those patients. They are patients, they are geriatrics, but the problem, we don't care enough about them, particularly in the overcrowding situation, as you have seen in everywhere. The overcrowding, here is the map of Europe. Where are the overcrowding problem? Everywhere. And as you may have seen, it was worse after the COVID period. So we have a lack of beds. And why our patients are coming? Here are the data from Europe. They're coming in emergency department because they don't have family doctors, they don't have a GP available, they have for financial reasons, they have many reasons for coming emergency department, but those patients are not responsible of the main problem of overcrowding. The other problem of overcrowding is the lack of beds, and it's the output patients, and as Roger said, it's access block also. So we have many reasons to have quite worried about the situation in Europe. And we have violence. We do have more and more violent patients in our emergency patient department because it's not a safe place in the emergency department. We have a lot of reason for that: alcohol, drug, and do not forget that the nurses and nursing staff are the higher risk of be harmed on the emergency department. We have a reason for that. Take, for instance, agitated patient coming in emergency in the waiting room. This patient is coming, he's getting agitated, and the other guys are quite under pressure, that the pressure cooker effect, and are waiting for hours, they waiting for long. And why the patient is coming in front of me? Why? And it's a better and better system because they're waiting for hours. Nurses say you don't have a problem, urgent problem. What happened then? It's the explosion. That's the patient die in emergency departments. It's in the media. And the burnout, I could not come again about the situation. It's all over the world, and particularly now. And after the day after with the COVID, it's worse now. So the burnout, we have a lot of doctors and nurses that are living now. They don't have the feeling that they can stay. So what we can do now? About some data, they said that maybe we need to organize the hospital with a better good work environment for nurses first, and we have to focus on nurse because we could have a better quality care. you can tell me that we need nurses also for that. If you take the example of Sweden, they are a teamwork organization program to organize and to make a safety program and a workplace environment for nurses, and the attitude, and they have quality care better organized with this in Sweden. So we could take the example of the Swedish hospital they have done. So the situation in Europe is not really quite high. We need to organize things together, and thanks to Bashar to organize an international conference, because we need to have our brains together, how we can face in a different way, because it's very important to work. We want to solve the problem very quickly for the overcrowding, of course, and the thing is we have to focus what are the main threats we are facing, how we can be attractive for our emergency departments, and because we need to reorganize our emergency department and organize and take our resources. So I would like to thank you, Teşekkür ederim, and sorry, Joe Roger, for the pictures, because it was necessary for me to make that joke. Thank you.
Eric, thank you. That brings the formal presentations to an end, but we've now got an opportunity to involve each of the speakers with regards to a bit of discussion. If I could just ask Paul and Srinath if you are still in the room. If I could ask you to share the microphone on the far side of the stage, it might be easier. And then we've got Eric on the line still. So, first of all, Paul, I want to say, thank you for training so many emergency physicians. Can you export?
The question is, can we export some of our emergency physicians? Interesting you ask that. A lot of our younger physicians want to work elsewhere. And I think conferences like this are something that, I've talked to Dr. Abdel Balou previously that he wanted to come and work more in the US. I think we need to look at how we can open our borders for physicians. I think it'll help not just to unload some of our U.S. workforce, but I think in exchange of ideas, I come and I learn something from Dr. View and Dr. Dickerson, you and my Turkish colleagues, and every single time I come to one of these conferences. So I think we really need to look at that, and I have to tell you, if you're looking for American emergency physicians that are well trained, I think it's a matter of putting that out there and making sure there's a mechanism for that to happen. A lot of our physicians are young and incredibly intelligent, and many of them speak other languages as well. So I think there's that potential.
I was actually also referring to there are existing programs. I know the global emergency medicine programs like out of UCSF have been doing great work and assisting with setting up emergency training programs. So whilst it's a bit of a flippant comment on my behalf, I think there's already some of that in place, which has been well used. But I think your comments regarding almost an international force of emergency physicians that can respond where there is need is probably a good thing. What we don't have, and it seems to be going all around the world, listening to what Eric had to say, and yourself from the US, and certainly from the South Africa and the African continent, is what are we doing about emergency nurses? Because that seems to be a global critical situation. If I can bring Eric in there, what ideas would you have to try and keep nurses happy on the one hand, skilled on the other, but still be able to manage the patient workload that we are all being faced with?
That's a great question, Roger, because when we ask the nurses, and after COVID period, they want to change the job. They don't want to be a nurse anymore. So that's the main concern, that we can focus on it. And we asked and we talked many times to the nurses, and they say it's over. We had a discussion with colleagues from US. They said exactly the same point. I don't know why, because they have the feeling that maybe they're scared about that, but they don't want to work anymore in the same situation. So to be attractive, of course, we could talk about the salary, but it's mainly working condition, training, and training our nurses, and maybe having a new perspective for nurses. For instance, we are working on a program in France to have the equivalent of the nurse practitioner. We didn't have for 20 years, and so we are starting a new program for nurse practitioner training, for a 2 years training program for nurse. So maybe it could be a new job to be attractive for nurses.
Thanks, Eric.
Roger, one of the things that we are looking at in the U.S. is that nurses in the U.S. take about 3 to 4 years of training. And so we're looking at whether we train nurses at a lower level than a registered nurse, an RN, as a medical assistant, which takes potentially 6 to 8 months of training, or an LVN, which takes 2 years of training, and unload some of the jobs that the nurses don't want to do, that's, quote, burning them out, unquote, and really trying to figure out if we can make all of these jobs a little bit more attractive. And same thing with physicians, is take away some of the jobs that we don't want to do, that doesn't require our skill level, that we're forced to do. And I think that's what we're hearing from our younger physicians that are a little bit more insightful, that I don't want to do this anymore, or I don't want to do this job anymore. And I think we have to listen to them, and I think they have to speak up and make those suggestions.
Thank you. I just want to make a short comment on the availability of staffing and the future of emergency medicine. Basically, when people go through programs and they graduate and they train and they work in different sites, as we move along, throughout the years, some people they find that they have probably different interests, like in finance, in legal, in admin, or even in the specialty of emergency medicine. They look at emergency medicine probably at a stage and they want to do something like, something more outdoor, like wilderness, or even something like special operation medicine, like HIMSS and Medevac and all that. So I think this is a tool that probably institutions around the world want to tap into. First of all, to avoid burnout for emergency physician. Second, to explore other skills that an emergency physician or an individual or a nurse or an EMT or a paramedic has at a stage that he was too busy during his residency or the first few years of establishing himself, is actually to have probably an international umbrella to train people like that and put them in a more probably accredited programs. Not only this will feed back into emergency medicine and disaster and a global event, but it certainly would probably have a better response in terms of disaster like flooding or pandemic, or even unify the scope for payment, for example. And that's just a thought.
If I can pick up on two things, I think there's been some really great points made. So in our nursing system, we already operate on a 3-tier structure where the RNs are the chief nurses. We have nursing auxiliaries and staff nurses, which range from a year to 2 years to 4 years of training, and then there's specialty nurses on top of that. The difficulty that often comes is that from a financial perspective, the hospitals see that why would they need to have any registered nurses, because the physicians can take over that role, and then you're paying a lower salary. So we found that we've not gained much from that. And with regards to, I think it's an amazing thing to be able to allow staff to develop in areas of their interest. The difficulty often, and I'm sure we've all sat when you're running departments going, yes, I want to support an individual, but in supporting that individual, I could threaten the rest of the team. And that is often the difficult tightrope that we are needing to walk. I am also quite staggered that there are more graduating emergency physicians in the US than there are on the African continent. And that's you graduating those numbers each year. But it brings me to my second question for you, Paul. You've stated that emergency medicine in the US is 50 years old. It's one of, or not the oldest country, or not the oldest country, shall we say the grandfather of emergency medicine as specialties globally. So it's something that we've not faced before, is looking at how can emergency physicians work until retirement at a pace that is often required in busy emergency departments. And the natural progression has always been into leadership or academics or something like that. But do you think that emergency physicians can be a pit doc till the age of retirement or death, whichever comes first? And I do note Lewis has got a question, so if I could ask Paul to answer that, and then I'll take Lewis.
I think, Roger, this is a great question, is can you be a pit doc till your 60s? I have to tell you, I've worked alongside a lot of the physicians that I worked with were 60 plus. And I have to tell you, it's a more difficult job as you get older. I'm looking into the audience, and when I was 20, 30, 40, 45, doing a night shift was easy. It's more difficult now that I'm in my mid-50s. And I still do them from time to time, but they're much more difficult than I recall them being when I was younger. So I think the issue here is there probably needs to be some type of seniority for the older emergency physicians, that they work less nights. And so I think that is probably the best solution. Maybe they work a few more weekends and a few less nights. I think that seems to be the right mix. That also takes off a little bit of the younger physicians that have time with their kids during the weekends. So I think that's the mix right there. It's, not a perfect system, but I think that's how I would address it.
Thanks. You've got a microphone. Great. Thank you.
Hi, I am Carlos from Mexico. They are the grandfather, but we are the second one. We have 37 years, and we had 37 years of emergency medicine in the world. So we are the second one. One of the things happening in the emergency medicine is that we need to tropicalize the emergency medicine in different countries. Every country has his own problem. So if you try to compare with the United States or with France, they have problems for the states because the medicine practice in the states is defensive for the states. If they don't do it correctly, they sue, and they have big problem for this. So I think the emergency medicine, I see the evolution for the 37 years. So at the beginning, like Paul said, we have less tools and we resolve the problems. Now we have a lot of tools and we make more mistakes. Why? Because if we have, one of the things happen is when, I remember 15 years ago when Imbaya, Gunnar Ollner, probably you know Gunnar Ollner, was the president of the USEM. At that time, he came to Puerto Vallarta in Mexico and he said, well, now in Switzerland, we are closing the emergency room, and say, you are closing the emergency room? We are overcrowding all the time. How you can do that? So, because they start to organize long time ago. But when you compare this with the countries like Mexico, other countries in Latin America, also in the United States, all the time they are overcrowding. You see in the States, patients start hour and hour waiting for something. In Mexico, if you go to the emergency room, you need to wait 1 week or 2 weeks to get CT. So I think every country has its own problem. My suggestion is, first of all, we need to see. Europe, they don't have all countries recognize the emergency medicine, first of all. Second, for example, Spain, 4 weeks ago, they go to the Congress, and they don't accept it. But they have fighting for 25 years or something like that. Eric, you know better than me how many years they're fighting, but they don't recognize. So we need to training that the people is working in the emergency room. I know many people is general practitioner, internal, but if you want to work in the emergency room, you need to resolve the problem for the emergency room. So probably you don't want to be specialized, but you need to take the correct courses to improve your knowledge to resolve the problems, first of all. Second, who held the doctors in the emergency room? The nurse. Sometimes the level that they have the nurse between the doctors is too high, too different. So we need to prepare people to help the doctor to resolve the problem. Because sometimes, who make the triage? For example, in Mexico, you arrive, one people is secretary, he have probably elementary school, and she decide this patient is sick or this patient is not sick, and waiting. In similar countries happen the same. So we need to do something that the access to the emergency room need to be quick, good, gentle, and effective. But you don't need to spend too much money to do that. You need to prepare the right people in the right place, in the right hospital to resolve the problem. The pandemic showed us how important is the emergency room. At the beginning, we saved a lot of lives. At the beginning, we are heroes. 2 weeks later, 4 weeks later, the heroes was the ICU doctors. Excuse me, we take the care for the patients, but they don't remember exactly what's going on. So if we work together, we'll be stronger and better, and we can resolve many problems around the world because we are similar ideas, similar knowledge, and work together and be successful in the couple of days. We need to make re-engineer to create ways in the wayside to fix it, the holes that create the pandemic in the emergency room and also in the system.
Carlos, thank you. I think there's some, if I can pick out some very important points that you've made, is that I call it the hero to zero phenomena, and it's something that we face in emergency medicine all the time. And you've encapsulated it well with how it applied in the COVID response, is a hero 1 minute and a zero the next. The second, I think, is the way that emergency departments are being used by the population is often a reflection on the expertise that are perceived to be there. And it's something that's being picked up by Eric in his presentation and by Paul and Srinath, was that we are seeing an increase in the number of emergency department presentations in favor of other areas within health systems. And that may be from a financial perspective, it may be an availability perspective, but I think a lot of the time it is seen as an expertise. If they go there, they will get the problem diagnosed and sorted because that's what emergency physicians do. There's also a perception that they will wait less time, which I don't think they've, certainly if they've sat in my waiting room of my emergency department, that's certainly not true. But thank you for your comments. I think some very valuable input made there. Sorry, could we have the mic back on there? I can't hear you. There we go.
One point more. When you're talking about the retire, you need to think about it. What is the period of the time for the sport guys? For example, Messi, Cristiano Ronaldo, Jordan, they have one period of the time. 37 is all. Like Paul say, when do you try to work in the emergency room? I think the best time to work is at the beginning, 20s, 30s, 40s. And then you need to take other positions, like training, like teaching, but you don't need to go out all the time because you are the values that you have, you need to teach for the new guys. The new guys need to understand better than us to advance quicker and in the best way. Because one of the things happen now is that many of doctors, like you said, the burnout around Europe and around the world they affected our population. So we need to create, don't go away the old doctors, support for the teaching, support for the program, but stay there because you are very helpful for the system.
All right. Any more questions?
May I add a comment?
Yeah.
Yes.
Go ahead, Eric. Yeah.
A quick comment about to summarize what you said, and I agree with one main point that Roger said. We are always on the front line, and emergency medicine. The creation of emergency medicine was in 1974 in UK, and then in Ireland and USA. And that evolution of emergency medicine are still the same concept. We are on the front line. When we create the pre-hospital EMS in France, it was just because we had a lot of road traffic injuries and we have patients dying before they come in the emergency department. It's not the problem anymore. We reduce to 10,000 to 2,000 patients who die for road traffic injuries. But the main thing we have, with the exception of India and China, they still have a lot of concern, and Turkey, about the road traffic injuries. In Europe, it's mainly medical problems that are coming through emergency departments. But the thing we are facing for now is we still are pioneer of emergency medicine, and we live day after day a new concept. Take the example of the COVID. No one in the room and no one like myself have faced the pandemic like that. We were the first to face that, and we deal with that and we try to organize. So emergency medicine is also to adapt our system to the disease that like we have, and we will have to face it. And I agree with Carlos Garcia, as he said, that we do have a lot of things in common, but we have to adapt our system on our own system of our own country, because we have a different concern about the system. I will be really lucky to take the example of the emergency physician in USA. I would love to have a huge number of emergency physicians in my department, but we don't have, so we try to find some issue for that. But that's very interesting talk we have together, because I think we still are pioneer of this creation of the specialty. Thank you.
All right. Thank you, everybody. Thank you.
Enjoy lunch.
Thank you, guys. Take care.
Thanks, Eric.
Bye-bye, Eric.
Bye, friends.
And I want to give the mic to my close friend Hikmet from Atayurdu, Uzbekistan. We are in very good collaboration between Turkey Emergency Medicine and Uzbekistan. Yes, Hikmet, please.
Thank you very much. Yes, indeed, we are collaborating for more than 5 years, and it's a great honor and pleasure for us. It's quite challenging to start after lunch session as usual, and this is an endless battle of curiosity with physiology, but nevertheless, let's start. So, as Bajar Hojam has said, it's our really great pleasure and a privilege to invite here Professor Josep Brugada for his topic, sudden cardiac death. Por favor, tome la palabra.
Thank you very much, Dr. Andarov, Dr. Canterbury.
This one, next page.
Okay.
Next page, and laser. You hold,
Translation?
hold push, yes. Hold push button. Yes.
Okay. Thank you very much. So I will talk in the next minutes about sudden cardiac death, and I will try, first of all, to remind you the definition of sudden cardiac death, which is a form of death which is natural, which is due to cardiac causes, unexpected in time and form of presentation, that is always preceded by sudden loss of conscience, that happens in the next hour after initiation of symptoms, and this happens in someone with or without a known cardiac condition. As you know, the final rhythm that produces sudden death is, in the majority of cases, ventricular fibrillation. But there are other rhythms that might lead to the same situation, which is the asystole, complete AV block, or electromechanical dissociation. But basically, in our interest, the most important one is ventricular fibrillation. Practically any form of cardiac disease can, at the end, produce sudden cardiac death. But basically, we are dealing with ischemic causes, with myocardiopathies like hypertrophic, dilated, or arrhythmogenic, but also some electrical conditions like the long QT, the short QT, Brugada syndrome, but also other conditions like the postoperative congenitals, cardiac amyloidosis, etc. All of them at some moment can produce sudden cardiac death. So if we talk about ischemic, we're talking about number one cause of sudden death in our environment. In Europe, number one cause of sudden cardiac death is acute myocardial infarction. So during the acute phase of the myocardial infarction, the cells get with ischemia, and they complain about this ischemia by having pain, but also by producing ventricular arrhythmias that can produce ventricular fibrillation and sudden death. So if we want to fight against sudden cardiac death in our environment, we have to fight against acute myocardial infarction and prevent acute myocardial infarction. When we are dealing with patients that have already gone through an acute myocardial infarction and have survived the myocardial infarction, in the chronic phase of the myocardial infarction, there is also a risk of having sudden cardiac death because of the occurrence of electrical circuits in the area of the myocardial infarction. The bigger the myocardial infarction, the most chances that during follow-up ventricular arrhythmia or sudden death might occur. Although in the last years we have learned that it's not only a matter of the size of the myocardial infarction, but you see here that a small myocardial infarction, very homogeneous, is a non-arrhythmogenic scar, but also a huge myocardial infarction, but very homogeneous, it's also non-arrhythmogenic. On the contrary, you can have a small myocardial infarction which are very inhomogeneous, or large myocardial infarctions, very inhomogeneous, which are really arrhythmogenic. So the point is that probably in the future we'll be analyzing the risk of sudden death in a patient post-myocardial infarction, not only because of the size of the infarct, but on the quality of this infarct and the survival of cells producing an inhomogeneous scar, which is more prone to arrhythmias than an homogeneous one. When we're dealing with dilated cardiomyopathy, we're dealing with probably what has been called the pandemic of the 21st century, because the increase in the number of patients suffering from cardiac insufficiency, dilated cardiomyopathy, because of the increasing age of the population, increasing risk factors like hypertension, diabetes, obesity, etc. Remember that 50% of the deaths in patients with dilated myocardiopathy are sudden death because of ventricular arrhythmias. So we have to treat the cardiac insufficiency, but also we have to prevent the arrhythmias in this population. When we're dealing with hypertrophic cardiomyopathy, here we are dealing with a genetically determined disease that produces a hypertrophy of different parts of the muscle, and this hypertrophy produces arrhythmias, many of them ventricular, many of them polymorphic, and many of them lethal, that might kill the patient by sudden cardiac death. And remember that hypertrophic cardiomyopathy is the principal cause of sudden death in patients younger than 40 years of age, especially sport practitioners. We also have arrhythmogenic right ventricular cardiomyopathy, which again is a genetically determined disease that produces changes in the muscle, basically in the right ventricle, but also sometimes in the left ventricle. And these changes produce the occurrence of islands of tissue in this muscle, being the basis for the occurrence of ventricular arrhythmias and sudden cardiac death, again in young population and again in sport people. However, there are a number of patients, around 20%, who had sudden cardiac death but do not present with a structural heart disease. They have a normal heart, and these are the patients like this one having ventricular fibrillation but a completely normal heart. In the last 30 years, we have learned about a new category of diseases that was unknown to all of us 30 years ago. That's what we call the channelopathies. And the channelopathies are the long QT syndrome, the short QT syndrome, the Brugada syndrome, catecholaminergic polymorphic VT, or malignant early repolarization. All of them are diseases that were unknown to all of us 30 or 35 years ago. And we understood that by looking very carefully at the electrocardiogram, we could identify some signs in the electrocardiogram that were explaining us that something was wrong in this heart, electrically speaking. Why we call that channelopathies? Because these are diseases which are familial, so they are genetically determined, but affect the channels that regulate the flux of ions across the membrane. And these channels, if they have a mutation, they will not work properly, and they will produce some signs in the electrocardiogram, but also might produce some electrical gradients in different parts of the heart. These electrical gradients leading to the occurrence of ventricular arrhythmias and sudden death. This is a patient with a long QT. Please look at the very prolonged QT interval, 640 milliseconds, corrected by the frequency at 584, extremely prolonged QT interval. When we have this type of ECG, and this ECG belongs to this lady here, you see that 7 members in her family have died suddenly because of the prolonged QT interval, and she was the only survivor in this family. So it's a very, very malignant form in this family of the long QT. This is a patient with Brugada syndrome. Look at the ECG, which shows this ST segment elevation in right precordial lead, simulating a myocardial infarction, which he has not. And when you find this type of ECGs, there is the risk in some patients that ventricular fibrillation occurs and the patient might die suddenly. Again, we're dealing with a familial disease. This is a family with Brugada syndrome. This guy here died suddenly. There are other 8 members affected in this family, and this allowed us to identify a mutation in the sodium channel that was responsible for the disease. This is the first patient we ever saw with the Brugada syndrome. That was in '86. In '92, we published the first paper. We defined the characteristic electrocardiogram. We understood the mechanism leading to these anomalies in animal models. We understood that the patient should be protected with an ICD. We could define in 1998 the first mutations in the families with Brugada syndrome. In late 2010, we could, for the first time, do some ablations in patients with Brugada syndrome in the epicardium, and certainly the future will tell us how to change the genetic defect in these families to normalize everything. Look, that it took 30 years to go from the initial description to the actual reality in the patient with Brugada syndrome, and we have learned a lot, we have advanced a lot in how to diagnose, how to risk stratify the patients, and how to treat the patients. We have also mutations in the potassium channels, like this one, producing this very prolonged QT interval. Look at this T wave, very abnormal, giant, negative T wave in left precordial leads. This is a very dangerous situation. This is a very high instability from the electrical point of view, and this patient might go into ventricular fibrillation at any time because of this very highly unstable electrocardiogram and repolarization defect that might produce certainly some arrhythmias and producing sudden death. So when we're dealing with the long QT, we have the long QT3, which is the one affecting the sodium channel, but then we have the 1 and 2 that affect the potassium channel. So the result at the end is the same by different mechanism. The result is that the repolarization is prolonged, so the QT interval is very much prolonged, and at the end, ventricular arrhythmias, sudden death can occur because of this gradient between different parts of the heart. Also, we described in the year 2000 the short QT interval, the short QT syndrome. We saw these patients, these first initial patients in the year 2000, especially this one here, that was a lady, 25-year-old, that had a syncope. And we received the ECG of this patient, and we thought that it was a mistake because the QT interval in this patient is no more than 200 milliseconds, extremely short QT interval. So at that time, we asked for a repeated ECG because we thought that the machine was not working properly, and we received the same ECG, so we understood that this was probably the first case of short QT syndrome ever described. Unfortunately, this lady, this was a Friday evening, and we asked the lady to come to our hospital, but the lady was living 100 kilometers away, so she decided that she will come to our consultation on Monday because she had a very young boy of 5 or 6 months of age, and unfortunately on Sunday morning, this lady died suddenly. So Then we learned that this was a familial form. Here you have some families with the short QT syndrome. Look at these very short QT intervals, very tall T waves, and very short QTs in families with sudden cardiac death. So probably this is the most malignant of all the channelopathies because of the very short QT interval. There is a huge window of vulnerability in these patients, and any arrhythmia, any extrasystole might produce ventricular fibrillation and sudden death. That's why probably there are very few patients described with the short QT syndrome all over the world, probably because they are dead. This is a polymorphic, bidirectional ventricular tachycardia, and this is specific from a condition called the catecholaminergic polymorphic VT. Again, a familial disease, genetically determined disease produced by a mutation in the ryanodine channel. The ryanodine channel is the channel that regulates the flux of calcium inside the cell. And during mental or physical stress, the flux of calcium increases. If the patient has a mutation in the ryanodine, this flux cannot occur, and there is an accumulation of the intracardiac calcium, and this produces an intoxication of the cell, and finally produce this type of arrhythmias that you see here appear during a stress test or mental stress test. This is the ryanodine channel and how the calcium accumulates inside the cell and produces this type of arrhythmias. Finally, the last situation described is what is called the malignant early repolarization, which occurs in patients having this abnormality at the end of the QRS complex, like an early repolarization that in some cases might be responsible for the occurrence of ventricular fibrillation. In some patients, there is an overlap between this early malignant early repolarization and Brugada syndrome, and still it has to be studied in the future. At the end, all of these diseases produce ventricular fibrillation because of this electrical gradient between different parts of the heart. So we can say that genetic studies have identified a new category of diseases responsible for syncope and sudden cardiac death in patients without demonstrable structural heart disease. That's what we call channelopathies. The good news is that if you look carefully at the ECG, you will find the signs to identify the patients at risk. So be careful and read carefully the ECGs and learn how to identify the patients that might be at risk. So, of course, in the patients that are recognized as patients at risk, we have to protect them. And we protect them basically by using implantable defibrillators. As you know, implantable defibrillators are extremely reliable devices that identify the ventricular arrhythmia and treat them very effectively in the majority of cases. But we know, and you know as emergency physicians, specialists, that time is what counts. So not everybody can be identified and can have an ICD implanted. The majority of patients that are at risk for sudden cardiac death do not have an ICD implanted because they have not been recognized. And we know that every minute that lasts, we have 10% less chances of surviving. So we need early defibrillation, and early defibrillation requires, of course, very good emergency systems, but also we need public access defibrillation that might allow for the general public to use these devices and to treat the patient waiting for the emergency system to arrive. There is a study in Japan that compares the number of public defibrillators installed in the countries and the number of patients that are shocked when they have a cardiac arrest. And of course, the more devices you have in the street, the more probability that you will be shocked by a bystander if you have a cardiac arrest. And this is my last slide. This is the number of deaths in car accidents in Spain all over the last years. And you see that they did a very good job, because you see that from the 60s we had an increase maximum in 1989, and since then the decrease is dramatical. So they did a lot of very good jobs, a lot of investment, a lot of money, a lot of fees, a lot of fines if you were too fast in the street, you were not having your protection, whatever. So a lot of money invest to go from almost 6,000 to 1,000. Do you know how many patients died suddenly in Spain? 10 times this number. And the number or the amount of money that is invested is 10 times less. So, of course, this is very important, because the politicians should also understand that sudden cardiac death is a major public problem, and investment in preventing sudden cardiac death should be at the level that it deserves for the number of patients suffering from it. Thank you very much.
Thank you very much for this great presentation. I think we can take the question, the last. Yeah, okay. Okay, thank you very much. We will take the question later. Okay. Yes. Now I want to invite the second speaker, Dr. Hikmet Anvarov, about aorta dissection.
Thank you very much. Herkese merhaba. So it's a really great honor to me to be here with you again. And as I've taught you this morning, the main focus in our hospital in Uzbekistan is on the ascending and descending thoracic aorta. Yep. Closer. Okay. Is it good now? Thank you. So some protocol things, I have nothing to declare, only I would like just to stress the contribution of my angio and cardiovascular department in designing these slides. So the dissections of aortic aneurysm is, as you know, all the condition characterized by a rupture of the inner wall of the artery intima with the formation of the false passage for the blood. And about 50% of patients with untreated aortic dissection will die within 2 days, maybe, is a risk of death within the first hour for acute aortic dissection is about 1%. So time matters. In large medical study, including almost 1,000 patients with aortic dissection, almost a third of them died within 2 days, and 2/3 within 2 months, and almost 90% within 3 months, and almost all of them within 6 months. So it's really a huge problem. The frequency of occurrence due to several studies is it's about 3 per each 100,000 population, and average almost 1,000 cases per year in my country with a population of 33 million people. So all of us, we well known about the types of classification of aorta aneurysms. There is 5 grades by Svensson, and also the most common things is Stanford's and DeBakey classifications. So the aim of the study, what we held in this year in our hospital, it was to evaluate the direct results of the first experience in surgical treatment of ascending aortal dissection aneurysm type A by Stanford. So these are materials, the retrospective analysis. We had 6 patients which we underwent for the surgical interventions, because the closed transcutaneous interventions has been described on the morning sessions. I would like just to stop more on the surgical ones. So 2 of these 6 patients had concomitant ischemic heart disease. In one case, we obtained the grade 3 of aortic valve insufficiency, and in one patient also the intimal tear was located on the proximal part of the aortic arch. So all surgeries were performed using the method of the in the stopped heart or the own pump with the artificial blood circulation. And here are the results. So average duration of the circular arrest was about 45 minutes, and the temperature we decreased it for less than 22 degrees. And of course, the retrograde hypothermic cerebral perfusion we provide in all patients. Here are some demonstrated things. We used the prosthetic for aortal arch and for descending aorta. Here are some stages from the surgical part. In 4 cases, the patient underwent supracoronary replacement of the ascending aorta. In one case, the aortic root replacement as a Bentel de Bono surgery. In one case, supracoronary replacement of the ascending aorta was supplemented with arch replacement. And Vascutech vascular prosthesis was used in all surgeries. Biological glue also we applied. We didn't apply it. And coronary artery bypass graft was performed as a concomitant interventions in 2 cases. As I said, this was that Bentel de Bono surgery. So, in postoperative period, we saw the 2 patients with signs of stroke, unfortunately, and the mortality also obtained in 2 patients. In one case, we obtained encephalopathy, but required early tracheostomy for prolonged ventilation. The average blood loss was about 900 milliliters. So in tape A, aortal dissection, about half of the patient within the first 48 hours, the perioperative mortality in half of the patients with ascending aorta, and more than 50% in aorta arch. In type B, the presence of the complications mortality is the same almost, and the perioperative mortality is in between the one third and half of the patients. And other types of the surgery in ascending aorta, it's average about 5%, no more than 5% in our hospital. In a big dissection involving the thoraco-abdominal elements, it's about 11%. And in abdominal aorta, we consider more, moderately more easier. It's about 5% mortality, nevertheless. So, obtained experience of surgical treatment of descending aorta aneurysm showed that timely detection and surgical treatment, of course, can achieve satisfactory result with, let's call it, satisfactory, of course, in comparison. Mortality is about 1/3 of all patients. Otherwise, all of them will die. And further improvement of our result associated with the increase of the experience, of course. Thank you. Teşekkür ederim.
Thank you very much, Dr. Hikmet. We will take the question later, and I want to announce the last speaker. Everybody in Turkey know him, Roger Dickerson from South Africa. Please.
too short presentation.
Yes, it's very good. Wow, wonderful. I understand it. I
It's not
understand.
my
No, no, I understand that. Short translation is very good. Very good.
Emre sent me 2 days before that.
Yes.
I have to do it.
Because there are lots of topic and yes, they like, they interest, but very, very tired.
Good afternoon, everybody. I'm a great fan of movies from the 70s and 80s, and one of my favorites was Dirty Dancing. I don't know if anyone remembers that, or looking around the audience, I'm not sure if anyone was alive when that was actually on the silver screen. But one of the comments made was, nobody puts baby in the corner, and I hate getting poked into the corner. So I tend to move. I apologize if I make you seasick, but we'll see how we go. So this is my hometown of Cape Town, and I work at New Somerset Hospital, which was actually the first hospital built in South Africa, purpose-built, and was actually the first teaching hospital of the university in South Africa. It is positioned in the waterfront, and so it's a really difficult place to work. But when it was first brought about, it didn't quite look the same. And this was when they were still constructing it back in 1806. But let's talk about this afternoon. Now, it's an interesting topic, and I must admit, I have to declare that I was a substitute. It was a topic that one of our esteemed colleagues had chosen, and he was unable to make it. And I must admit, it was a very interesting topic. And so I'm literally hoping that whilst I know Prof. Kande is a great fan of soccer, I'm really hoping that I don't score an own goal when I go through this topic. And what we're going to be looking at this afternoon is the what if. We're going to be looking at the what if our gold standard of managing patients is not available. And I hate what if scenarios, but it's something that we do need to plan for. Because unfortunately, we don't all work in scenarios that are often portrayed in Hollywood. I have never been in the situation where I have been able to park my high-heeled shoes under a bed, or where martinis are brought to me in an on-call room. But the one thing that Hollywood has shown is that in a golden standard environment, anything can be done. Now, I'd like to ask a question. If I look around the room and I ask the question, who here has access to PCI in their facilities? Can I ask you to raise your hands? Hold them up high. Okay, so it's probably about 5% of people in the room. Can I ask you to keep, for those who put your hands up, keep them up for me? Nice and high, wave them. I'm old, I don't see so well anymore. Good. All right, keep them up. This is your calisthenics for the afternoon. Okay, keep your hands up. Now, for those of you who've got access to PCI on a 24-hour basis, or is it only during certain times? So we're looking, if I look around this room, thank you for your participation. If I look around this room, very few of us have actually got access to the gold standard in managing some of these cases. And so I'm going to talk through an approach. Now, for those of us who don't have PCI, thrombolysis does tend to be that savior of the universe. If we select it for the appropriate cases and we select it for the appropriate individuals, it can certainly save lives. Now, if we think about the indications for thrombolysis, there are many applications. Some of them apply to acute cardiological emergencies, but there are many others that apply. So looking at the management of acute stroke, for instance, or for pulmonary embolism, or looking at peripheral vascular matters. But if we're looking at it specifically with regards to cardiological emergencies, they tend to become far more narrowed. So if we think about the concept of the acute coronary syndromes being a scale or a realm, a continuum, where it starts with something as simple as angina pectoris on the one side, it then progresses from angina, it will progress onto unstable angina. We'll then end up looking at something like a non-ST elevation myocardial infarction, and there we can make true interventions with regards to thrombolysis. We're looking at your true STEMIs. Now, if we look at this continuum, this spectrum of the acute coronary syndromes, the application of thrombolysis is actually in a rather small subgroup. And the reason for that is that not only do you have to have a STEMI diagnosed, you need to confirm that it is not one of the channelopathies that Prof. Brugada spoke through, that we often can mistake it for. We also need to look at things like, do we have access to PCI? And if we don't have immediate access, what time frame would we have access to? And there's been various timelines that have been postulated, but the suggestion is that if you don't have access to PCI within 2 hours, we should be proceeding with thrombolysis. Now, in the facility that I work, we do have a cath lab, but it doesn't operate on a 24-hour basis. And so, depending on the time of day, will change our approach to these cases. So time is an aspect. There are indications and contraindications that need to be applied from a patient perspective, and they need to meet the diagnostic criteria. And so it really is a very small subgroup. That very small subgroup of the acute coronary syndromes that can, in fact, be thrombolyzed. But now the problem that we often run into in these scenarios is that we use it as our base therapy. But if we are not able to access it for our patients, we start getting ourselves into a bit of a quandary. Because as you're aware in medicine, it's never as simple as a yes or a no. Because if we look at the things like the contraindications, and if there are absolute contraindications, that makes a lot of sense. And you'll see contraindications listed on thrombolytic checklists in many organizations and published in many journals, etc. Those are fairly finite. Those we can accept. The ones that pose quite a difficult thing for us are the relative contraindications. Because here, we are needing to apply our minds and balance risk. Balance the risk of an event occurring from the therapy that we are instituting versus the risk of a patient having a worse outcome from their primary pathology. And what it really does is that it ends up being a yes, a no, or a maybe. And it's the maybe group that gets us into a quandary. Because our decision-making isn't binary. Our decision-making often in emergency medicine is based on a lot of input with regards to how much information we've got at the time. And this can lead us to a vicious circle. We've got a patient who needs to be thrombolyzed, but meets a criterion that would be a contraindication. If we don't have access to PCI, what do we do? And if we look at all of the treatment protocols that have been published, it starts primary PCI is really the way to go. If you can't do that, then thrombolize. But now if you can't thrombolize, those patients should be going for PCI, but that's not available. And we end up getting ourselves into quite a vicious circle. I'm going to try and simplify this a little bit. And it's because I tend to operate best at 3 a.m., and when I'm operating at 3 a.m., I need to have things simple. So you've diagnosed a true ST elevation myocardial infarct. You ask yourself, do I have PCI available? And the 20 or 30 people in the room that have got PCI at their facility and have got easy access to it round the clock, that's the route that they will go. They will say to themselves, that's great, let's say yes, we've got PCI and we're going to proceed with PCI, and we know that that does have the greatest, better outcomes. So that's a green, that's good. The difficulty comes is that if our PCI is not available, and that is where we are needing to consider the thrombolysis. But before we can do that, we need to look at those contraindications. And again, it's not a yes or a no. If there are no contraindications, the decisions are easy. We can proceed with thrombolysis, and we need to do that as soon as possible to restore perfusion and save muscle. If the answer is yes, there are absolute contraindications, then we can't proceed with thrombolysis. And we'd have to consider them alternative maximal medical therapies to try and improve a patient's outcome, but we're not going to be able to save that muscle. But it's the middle group that often leads us to quite a bit of difficulty. And those are the maybes. And in that group of the maybes, we're needing to balance the risk. And I think this is where we find ourselves often in a position of difficulty. The green is the easy. The red is the easy. The difficult one is where we, as clinicians, are having to balance risk. Balancing the risk of an adverse outcome from our therapy versus the risk of an adverse outcome from the original pathology. And we can go round and round and round in ourselves trying to find a solution. But we know that in emergency medicine, there is something worse than a bad decision, and that is no decision. And that's often where we run ourselves into difficulties, that we're needing to make a decision with limited information at the time. And now there are a host of medical interventions which I'm not going to be going into here. We can look at the antithrombotic therapies, the good old aspirin, to try and stop that clot getting any bigger or propagating elsewhere. We can look at other medical therapies in an attempt to try and limit the damage, or if there has been damage, to try and improve the outcome. But it all comes down to that balancing of risk. Now, in the international session earlier this morning, Eric Review spoke about the pressure keg of the emergency department, and he very kindly put my head in a pressure cooker. And so, with tribute to Eric Review, who presented earlier today, I think we need to take an approach that I'm going to give his nomenclature. We need to evaluate the risk, the indications, and the contraindications. So we need to do an ERIC. And if you think about it, we're reviewing those factors, and we can do an ERIC review, or rather, an ERIC review. We need to evaluate the patient, evaluate the risk, and then make a decision. And it needs to be timeous. The longer we wait, the greater the pathology. The maybe group is the most difficult one that we have to manage. It is non-binary. we take risk ourselves, but at the end of the day, the patient takes the ultimate risk. Thank you very much.
Thank you very much. Baie dankie.
Dis 'n groot plesier, baie dankie.
Yes, thank you very much. I think we have time for the question or comment. Any question or comment for all speakers? Okay, we can start from Emre. We have question.
Hello, my name is Emre Atish from Karabük University. I have a question for Professor Brugada. Before your presentation, Professor Brugada, we had a patient who suffered long QT and VTAC. After we analyzed the ECG, we found that ECG axis was changing constantly. Is it a common sign of long QT syndromes, or is a bizarre thing?
Sorry, did you get the question? I'm sorry, did you get the question?
Sorry, could you just repeat that question? We were just struggling to
Yes. Before your presentation, we had a patient with long QT and VTAC. After we took the ECG, we found that ECG axis was changing constantly. So is it a common sign for the VTAC with long QT syndrome, or is it a bizarre thing?
I'm sorry, I'm having a close of the sound again. I'm getting close.
Okay.
Sorry.
It's a personal consult.
Yes. I'm sorry. Before your presentation, we see a patient who had long QT and VTAC attacks. And after we took the ECG, we found that the ECG axis constantly changing. Is it a sign of the long QT channelopathies, or is it a bizarre thing for...
What was the sign? What the?
Axis, ECG axis changing constantly.
Oh, the axis.
Yes.
Okay. Sorry, I'm sorry for that. No, the T wave, yes, but not the axis of the ECG. I mean, the axis of the ECG, if you mean the QRS complex axis, this is not a long QT sign. This is a conduction system disease sign. But if you have a changing in the axis of the T wave, then of course this is something that you should take into account, because it's clearly related to the repolarization. It is a very poor sign, normally indicates a very high risk. No.
Okay, thank you. And Iqbal, okay.
And thank you for all the professors for their great presentations. I want to add something about Professor Rogers' questions about the PCI. I think we couldn't get the question, or we misunderstood. In our country, more than 90% of the patients from ST elevation MI, they are underwent to PCI. And I have a question for Professor Brugada. The patients are coming to emergency or emergency department for the syncope or loss of consciousness or chest pain, and we diagnosed Brugada syndrome. But even they are stable. Are all the Brugada syndrome patients must underwent to the ICD replacement before discharge, or can it be delayed?
Proper got it.
Okay, so the first thing, we have to make sure that he has a Brugada. And that's the first thing, okay? Why I say that? Because there are many patients that do have what we call a type 2 or type 3 ECG and not a type 1. And this should not be classified as Brugada. This is just an ECG which is suspicious, but it's not diagnostic, okay? So the first thing is that you need the type 1 ECG to make the diagnosis of Brugada. If the patient has a cardiogenic syncope, I mean, if the patient has had a cardiac arrest and has been recovered, of course, you have to do whatever you have to do, and probably the patient should be on a defibrillator before it leaves the hospital. If the patient has a cardiogenic syncope, so syncope which is clearly cardiogenic with no prodromes, and you have a type 1 ECG, probably this is a patient that should receive an ICD. But be careful, because this is the minority of patients. The majority of patients who have a syncope or who have a chest pain or who have palpitations, and then they are diagnosed because they have a type 2 or type 3. Be careful. This is not yet a Brugada syndrome. This is not yet something that you have to treat as a Brugada. You have to do the test. Sometimes you have to do pharmacological tests to see whether you get the type 1 or not. And in our hands, you will always do an electrophysiological study to make sure that the patient is inducible before implanting the patient. You know that this is controversial in different departments, but we always do electrophysiological study.
If I could just, it pleases me greatly that you've got access in so many of your facilities to PCI. It's certainly not like that in other parts of the world, where we find that healthcare is very stratified, and cardiology, for instance, in the system that I work in, is considered a super specialty, and it's housed at the tertiary level hospitals. So it is a very small minority that will have primary PCI. And it's not only with regards to getting the patient to, and so if I look working in the metropolis of Cape Town, we should be able to get a patient to a PCI suite within the necessary timeframes. The difficulty is that we've got large rural areas with long distances, and getting a patient to those facilities becomes problematic. I previously worked at Chris Hani Baragwanath Hospital, which is in a township called Soweto, a very large tertiary academic hospital, but with a cardiology department that I used to have to pull out of the emergency department because they would come hunting for patients to take to PCI. And what it meant is that none of my residents ever learned how to thrombolize because the cardiologists were so active, it's not a complaint. It's great for the patients. But when I move and our residents go to other places, they've never had the exposure to the difficulties that thrombolysis can have. And it's easy when it's a true yes or a true no. That's easy. It's making that maybe call, balancing the risk of the relative contraindications versus the risk of the patient actually dying from the myocardial infarct. And also the difficulties of which thrombolytic to choose. Do you go a fibrinolytic or a thrombolytic, or what is going to be best for the patient? It also comes down to finances. In my facility, we have limited access to the true alteplase or any of the TPIs, but we've got free access to streptokinase. And so it becomes that difficult scenario of not only deciding whether the patient should get thrombolized or not, but then which agent to do it with. And I think it thrills me that you've got such free access. May I ask just to sign who here has thrombolized myocardial infarct? Maybe that was a better question to have asked.
Okay, thank you, Roger.
Okay.
Any another question or comment? Yes, Dr. Ayman, please.
Okay. Thanks, Dr. Borugada, for this excellent presentation. Do you know sudden cardiac death is a disaster, actually, and it's common in poor country like South Asian. Do you have any recommendation to have a screening plan, for example, in the school, for the student to screen for ECG to pick up who has the channelopathy, and is this any patient who has channelopathy, the ECG finding is present since birth or it changed with the age? From this, we can know what age we can screen if it is possible. Thank you.
Thank you. That's a very good question. That's one of my fights with administration and politicians, is that everybody should have at least one ECG performed during lifetime. I'm a teacher, professor in the university, and I always ask my people in the room, I will say how many they are, 22, 23 years old, my students, and I always ask them, how many of you have ever had an ECG? And it's always less than 50%. And these are medical students. So imagine in the normal population that is even less. So I've been fighting, and I keep fighting for the possibility that everybody has one ECG performed in live that will detect, of course, Wolff-Parkinson-White, long QT, short QT, Brugada. I might suspect hypertrophic cardiomyopathy, rhythm disturbances, whatever, you know. It's cheap, it's easy, it's innocuous, it's without complication. I do myself in the area where I live, which is an area of about 50,000 inhabitants in the north of Barcelona. I do every year an ECG to every single boy and girl in the school at age 14. Okay. Why 14? I don't know it very well. I decided some years ago, but I don't know very well why I decided 14 and not 16 and not 12. Probably 14 because there are diseases like hypertrophic cardiomyopathy that the abnormal ECG is only visible at a certain age when the heart is already big enough. It's true that you might miss some patients with some conditions before that, but normally if this is a patient with a genetic disease, normally you have some suspicion in the family, and then of course you do the ECG. But as a general screening, I think 14 is a good age. If you only have one valve, you only have one in your life, I would say 14. If I have 10, then I would say at 2, at 10, at 20. But if you only have one valve, I would say 14 is a good age. But I don't know why, but that's my feeling.
May I ask, in those screenings, how frequently do you pick up issues with these children?
Okay, so we do about 500 ECGs per year, okay? The first thing that is very curious is that 12% of the parents do not allow us to do an ECG on their child, which is something incredible for me. I still don't understand, you know. So look, this is free, I will do it, there is no problem. So of course we ask for a small record on medication or symptoms, family history, etc. And then authorization of the fathers to do the ECG. And 12% every year, 12% say no, so which I do not understand, but that's okay. Then on the 88% that we do, which is about 500 per year, we found 3% of ECGs which are suspicious of something, which are, let's say, not normal. And then, of course, we exclude here incomplete right bundle branch block and things like that. We don't care about that. So, abnormal. And then in this 3%, basically what we do is an echocardiogram, sometimes a Holter, sometimes a stress test, but basically an echocardiogram. And finally, we find 0.7% of ECGs that have something which is really abnormal, which does not mean that requires treatment, okay? But that they are normal and the patient should be followed up every year, whatever. So it's about between 3 and 4 ECGs per year, or patients per year, that has something that should be followed. Of course, we found Wolff-Parkinson-White, which is asymptomatic. We found some long QT. We found some suspicion of cardiac hypertrophy, or patients that do have a lot of extrasystoles, ventricular extrasystoles, and then you have to follow them. We had one with a suspicion of how you call that, an abnormal coronary artery that we could suspect on the ECG, and it had to be operated, so we found things.
If you take those numbers and extrapolate them to a country's population, those become huge.
Sure.
And those are numbers of lives that could be saved.
Yeah, but if you do that, it is like Why should you not do that once in lifetime? You know, and we are doing at 14, but maybe when you get your driving license, whatever. At some moment, that the majority of people do, not the military service, which was before, because now there is no obligatory military service, so you cannot have it. And of course, you will find things, and you will find things that you might, see every year, new patients coming, or patients that should be suspected of something, and of course you will have to do echoes and stress tests and whatever. That's true, but that's prevention.
Yeah.
Thank you very much, Brigada.
Thank you.
And we finished the time, and we have to give very 10 minutes, only 10 minutes. After 10 minutes we will come again for satellite symposium. Arkadaşlar 10 dakika sonra uydu sempozyumu sadece bu salonda var. Çekiliş yapacağız. İsimlerinizi yazdırın. İstediğinizi veriyoruz çekilişte, ona göre. Tamam. Thank you very much. Ortam. Çok teşekkür ediyorum. Burada bize verdiğiniz destek, kongrenin bir parçası olmak, burada bulunmak, hepsi her şekilde bize güç veriyor. İşte bu güç veren şeylerden birisi de uydu sempozyumlarımız. Bugün kardiyolojiyle başladık, kardiyolojiyle devam edeceğiz. Biliyorsunuz akut koroner sendromlar acil tıbbın en önemli kısımlarından birini oluşturuyor ve bizim uzun dönemde baktığımız acil vakalarında büyük oran kardiyolojik aciller olabiliyor. Yani %20'nin üzerinde, %25'in üzerinde gerçek acil vakalar için söylüyorum. Kardiyolojik aciller oluyor ve bunlara müdahale ederken çok daha dikkatli olmamız lazım. Çünkü gerçekten iyi tedavi, iyi sonuç. Yanlış, eksik tedavi, kötü sonuç çok belirgin olan bir hasta grubu. İşte bu önemli sendromda çok önemli bir tedavi, eski bir dostu inceleyeceğiz. Şimdi eskiden bilirler, filmler, bilmiyorum, bir Mehmet Hoca var beni bilen, bir de Zeynep Hoca, Zeynep Hoca küçük bize göre de, o eski filmler olur ya Yeşilçam'da, göğsü ağrırdı, bir tane cebinden bir teneke çıkardı, sarı teneke. Üstünde ne yazar onun bilir misiniz? İşte bilene ödül vereyim. Efendim? Firma olmaz ama firma söylemesin, o bilir. Trinitrin, sarı bir kutu. Nitrattı yani, trinitrat. Onu alırdı, iyileşirdi. Şimdi o dönem bitti. Ondan sonra spreyler geldi ya. Spreyler çok avantajlıydı bizim için. Filmlerde yer almadılar ama iyiydiler. Sonra spreyler ortadan gidince biz tablete kaldık. Şimdi yeniden hani popüler olma, daha doğrusu yeniden önümüze gelme şansı yakaladık. Onlarla ilgili de güzel bir sunum olacak. Profesör Doktor Zeynep Gökçen Çakır alkışlarınızla kürsüye davet ediyorum.
Daha fazla adım olsun diye biraz uzağa oturdum. Sahneye çıkmam zaman aldı. O arada adımlarımı da saymaya devam ediyorum. Ben kazanacağım inşallah diyorum. İndirdiniz mi uygulamayı? Evet, Başar Hocam zaten neredeyse benim anlatacaklarımı anlatıp bitirdi. Ben de size yine de kısa etkili nitratlarla, Başar Hocam'ın dediği gibi o eski dostla ilgili bir şeyler söylemek istiyorum. Yani çağları deviren, çağları yıkan, yeni çağ açan, orta çağın karanlığını sona erdiren kara barutun icadından sonraki en önemli kimyasal icat. İlk kullanışlı patlayıcı olarak icat edilmiş bir madde, gliseril trinitrat veya trinitrogliserin dediğimiz madde. İtalyan kimyager Sobrero bunu icat ediyor. İlk patlayıcıyı geliştiriyor ve kendisine progliserina diyor bu madde için. Ama daha sonra barış ödülüyle tanıdığımız İsveçli kimyager Nobel bu patlayıcıya çok büyük bir ilgi duyuyor ve en büyük gelişmeleri Nobel'in şirketi kaydediyor ve bu patlayıcıdan bir dinamit icat ediyor. Bu patlayıcıdan dinamit icat ediyor çünkü hem savaşların hem teknolojide hem sağlıkta en önemli gelişmelerin yaşandığı bir yüzyıl. Çok önemli gelişmelerin olduğu bir yüzyıl. Ve sağlıkta da aynı şekilde aynı teknolojide olduğu gibi daha fazla ne yapabilirim, yeni ne üretebilirim çabaları var. Bir İngiliz doktor bu trinitrogliserini inceliyor ve bundan ne için kullanabilirim sorusunu kendisine soruyor. Ama ondan önce Alfred Nobel, Sobrero'nun bu icadından dinamiti icat ediyor demiştik ve İsveç'te ilk dinamit fabrikasını kuruyor. Maalesef kardeşini dinamit kazasında kaybediyor, kendi erkek kardeşini dinamit kazasında kaybediyor ve ondan sonra ilk nitrogliserin fabrikasını Almanya'da açıyor ve sonra da Amerika'ya sandıklarla tren yolu yapımları için Amerika'ya sevk ediyor. İşte Red Kit hikayelerine nitrogliserinin konu olması bu nitrogliserinin Amerika yolculuğuyla başlıyor. Epey bir zaman geçtikten sonra daha birkaç sene önce Beyrut'ta yaşadığımız o kanlı patlamanın sebebinin de yine nitrogliserin olduğunu söyleyip insanoğlunun bu patlayıcı icadının, bu büyük keşfinin nasıl sağlığımıza faydalı bir şeye döndüğüne geçmek istiyorum. İlk kez William Merrill tarafından 1878 yılında anjina krizlerini tedavi etmek için kullanıldı ve aynı yılda Merrill bunu yayınladı, duyurdu. 1896'da ölümünden hemen önce de Nobel bir arkadaşına yazdığı mektupta, ki mektubu görüyorsunuz, orijinal halinin fotoğrafını da buldum. Dahilen kullanmam için bana nitrogliserin reçete edilmiş olması kaderin bir cilvesi anlamına gelen bir arkadaşına mektup yazıyor. Çünkü bu olaydan, özellikle de kardeşinin ölmesinden zaten çok etkilenmiştir Nobel. Nobel Barış Ödülü'nün de bu yüzden konulduğu söylenir. İnsanoğlunun bu patlayıcı icadı 130 yıl süren, Başar Hocam'ın söylediği gibi çok eski bir dost kazanmamıza sebep oldu. Tıp dünyasının çok eski bir dost kazanmasına sebep oldu ve güçlü bir vazodilatatör olarak şimdiye kadar tıp camiasındaki yerini aldı. Nitrik oksit üzerinden salgıladığı bu vazodilatasyon yapan maddeyi nitrik oksit üzerinden salgıladığını yıllardır biliyoruz ama 2002 yılına kadar hala bu konuda gelişmeler o kadar cazip ve incelemeler o kadar fazlaydı ki 2002 yılında da aldehit dehidrogenazın buna sebep olan mitokondriyal enzim olduğu keşfedildi. Kabaca organik ve non-organik nitratlar olmak üzere ayırıyoruz. Bugün üzerine en çok duracağımız gliseril trinitrat, nitrogliserin organik bir nitrattır arkadaşlar. Dediğim gibi nitrik oksit üzerinden yapar vazodilatatör etkisini ve guanilat siklaz bu dönüşümde rol oynar. Düz kas çeperinde, endotel hücrelerinin yüzeyinde meydana gelen bu enzimin indüklediği reaksiyonla nitrik oksit salınır ve vazodilatatör etki gelişir. Nitrogliserin nitrik oksit üretimini tetikleyerek veya onun eylemlerini taklit ederek birçok özelliğe sebep olur. Damarları genişletici birçok özelliğe sebep olur veya bizim istediğimiz vazodilatatör etkiyi sağlayacak birçok farklı eylem yapar. Bunlardan bir tanesi zaten bildiğimiz nitrik oksit üzerinden yaptığı doğrudan vazodilatasyon. Vazokonstrüksiyonu inhibe ederek dolaylı bir vazodilatasyon da yapar. Ayrıca vasküler endotolyuma trombosit salınımını engelleyerek antitrombotik etki de yapar. Antienflamatuar etkiyi lökositlerin vasküler endotelyuma yapışmasını engelleyerek yapar ve aynı zamanda antiproliferatif etkisi de vardır. Anjinadaki, daha doğrusu akut koroner sendromlardaki yolculuğumuzda Başar Hocam zaten ufak bir giriş yaparak başladı. Bu konudaki en son kılavuzdan aldığım bir cümle ile ben de sunumun en can alıcı bölümüne başlamak istiyorum. Nitratlar yalnızca arterleri ve arteriyolleri genişletmekle kalmayıp aynı zamanda seçici venöz dilatasyonunu da indikledikleri için hem art yükü hem de ön yükü azaltan benzersiz vazodilatatörlerdir diyor. En son 2020'de yayınlanan Avrupa Kalp Cemiyeti'nin kılavuzunda, akut koroner sendrom kılavuzunda. Bu özelliklerini de ve çok kullanışlı bir preparat, farklı farmakolojik şekillere girme özelliğine sahip tablet formu, sublingual tablet formu, ayrıca transdermal formu, sprey formu, birçok farmakolojik yapıya da ticari şekle dönüşme özelliğine de sahip çok kullanışlı bir preparat. Bugünkü konumuz aslında kısa etkili nitratların acil serviste kullanımlarıyla alakalı. Tabii ki en önemli yeri de akut koroner sendromlar burada teşkil ediyor. Ana kullanım alanlarımız. Çok yeni bir çalışma Türkiye çapında yapılmış geniş çaplı TÜRKMÜ çalışmasında bizim toplumumuzda en yaygın akut koroner sendrom bulgularının tipik göğüs ağrısı ve dispine olduğu vurgulanır. İşte nitrogliserinlerin çalıştığı ana yerde burasıdır. Tipik göğüs ağrısı ve dispineyi düzeltmek için çalışırlar. Gördüğünüz gibi şöyle kabaca size bir antianjinal ilaçları sınıflamış oldum. Nitrogliserinler hala 130 yıl geçmesine rağmen burada çok önemli bir madde olarak yerlerini alıyorlar. Farmakolojik ajan olarak yerlerini alıyorlar. Ve hala 2022 yılına geldiğimiz zaman hala daha nitrogliserinle ilgili review'lar, çalışmalar yapılacak kadar da önemli bir yeri var. Kardiyolojik özellikle olaylarda ve birçok tıpla ilgili birçok alanda çok önemli bir yeri olan ilacımız. Acil serviste kullanımıyla ilgili aslında tabii ki akut koroner sendromlar ve şimdi sıralayacağımız birçok nitrogliserin etkili olduğu tıbbi durum acil serviste gerçekleştiği için, ilk başvuru yeri acil servis olduğu için aslında nitrogliserinin de en çok kullanılacağı yerler acil servislerdir. Yine işte az evvel sunduğum çalışmadan aldığım bir bölüm diyor ki özellikle semptomların başlangıcından sonraki ilk 10 gün içinde mortalite başta olmak üzere erken kullanımın ne kadar erken başlarsa nitrogliserin kullanımı o kadar fazla etki eder. O kadar çok etki eder. Burada erken kullanımın altını çizmek istiyorum. Ne kadar erken başlanabilirse bu erkenlik saniyelerle, dakikalarla ölçülen bir erkenlik düzeyi. Onu saniyeleri, dakikaları geçtiğiniz zaman da günler içerisinde başlanabilmesi, mesela stabil anjinada bir an evvel reçete ediliyor olabilmesi çok çok önemli. Eskiden kullanıldığı, artık kullanılmadığı bir yer var güncel kılavuzların vurgu yaptığı. O da tanı amaçlı kullanımı. Eskiden göğüs ağrısının tipik vasfını değerlendirmek için nitrogliserin verilip eğer nitrogliserine cevap veriyorsa bu ağrının koroner sendrom olduğu yönünde, koroner arterlerden kaynaklandığı yönünde bir genel kanı oluşurken daha sonra özofagus üzerinde de özellikle özofagus spazmlarının da aynı şekilde nitratlara iyi cevap verdiği görüldüğü zaman bu ayırt edici özelliğinin olmadığı ve tanı koyma amaçlı kullanılmaması son kılavuzlarda özellikle vurgulanıyor. Bu görmüş olduğunuz 2014'ün AHA kılavuzu hali hazırda 2020 en taze kılavuz 2020'de ESC'nin yayınladığı kılavuzdur ve Klas 1C bir öneri olarak sublingual veya IV nitrat kullanımını erken başlatılmasını çok şiddetle önerir. Herhangi bir kontraindikasyon yoksa der. Sınıf 1C oldukça yüksek bir öneri düzeyi bildiğiniz gibi. Ve hemen algoritmanın başında burada gördüğünüz gibi antianjinal tedavi olarak ağrının tedavi edilmesinde nitrogliserin yine tedavide yer alır ESC'deki akut koroner sendrom algoritmasında. Bu çalışmanın önemi benim için şu, burada yer almasının sebebi, sizlere sunmamın sebebi şu. Bu çalışma nitrogliserin dilaltı spreyin 5. dakikasında, kullanımının 5. dakikasında hastaların %48'inde koroner dilatasyon yaparak iskemi bölgesinde reperfüzyon ile hasar oluşumunu gerilettiğini iddia etti. O yüzden benim için önemli. Güzel de planlanmış, güzel yapılmış bir çalışma. Tek merkezli, çift kör, prospektif, plasebo kontrollü bir çalışma. Ve 96 hasta sayısı da az değil böyle bir çalışma için. Dolayısıyla 5. dakikada hastaların yarısında neredeyse ciddi etkili olabilecek bir vazodilatasyon olduğuna vurgu yaptı ve tabii bu şekilde de Circulation'da yayınlanma hakkını elde etti. Bir review konuyla ilgili bunu şunun için koydum. Oral kullanım dozları için net bir öneri bulunmamakta diyor bu review'da. Biz IV dozlardan yola çıkarak oral dozları tahmin yoluyla buluyoruz diye hatta bir iddiada bulunuyor. Fakat klasik kaynaklara geçmiş, klasik review'larda, kitaplarda yer alan dozlarımız aslında belli. Translingual spreyde gördüğünüz gibi doz 400 mikrogram sprey 1-2 metreden puflanacak şekilde 5 dakikada bir tekrarlanabilecek şekilde ağrı iyileşinceye kadar verilebilir. Sublingual sprey için söylüyorum. Acildeki önemli kullanım alanlarından bir tanesi de acilin yine mayor hasta gruplarından birinde akut hipertansif kalp yetmezliği ve pulmoner ödemde tabii ki. Bildiğiniz gibi akut hipertansif tedavi ve pulmoner ödem, akut hipertansiyon ve pulmoner ödemin tedavisinde, temel farmakolojik tedavisinde vazodilatatör ve diüretikleri kullanırız. İşte nitrogliserin burada vazodilatatör olarak önemli bir rol oynar. Çünkü neydi? Az evvel gösterdiğimiz o kılavuzda yer alan cümleyle, vurucu cümleyle hem ön yükü hem art yükü azaltacak vurucu bir vazodilatatör etkisi vardı. Ve kalp yetmezliği belirtisi olan kişilerde oldukça faydalıydı. Bu da yüksek doz nitrat kullanımının düşük mekanik ventilasyon, düşük endotrakeal entübasyon yapılma ihtiyacı, kan basıncında iyileşme, miyokard hasarında azalma, hastanede kalış süresini kısaltma ve yoğun bakımda kalma süresini kısaltma ya da yoğun bakım ihtiyacını azaltma gibi kriterlerin iyiliğiyle alakalı olduğunu vurgulayan bir yayın. Ve yüksek doz IV nitrat kullanımının altını çiziyor. Fakat ben bu yüksek doza bir de erken kullanımın vurgusunu yapmak istiyorum. Ne kadar erken o kadar iyi diyen bir makaleyi de sizinle paylaşmıştım. Bir an evvel başlanmasının bu açıdan da yanınızda olmasının ve hemen kullanılabilmesinin, Başar Hocam'ın anlattığı Türk filmi sahnesi benim gözümün önünde. Çok da aradım aslında buraya görsel olarak koyabilmek için ama bulamadım. O beyaz saçlı amca cebinden işte ilacını çıkartıyor ve kısa süre içerisinde toparlıyor. Çok da aradım buraya koyabilmek için, bulamadım. Çok dramatik ve kısa sürede başlandığı zaman çok belirgin etkisi olan bir ilaç olduğu için bir an evvel başlanılması yüksek doz kadar önemli. O yüzden ben bu yayının yaptığı yüksek doz vurgusuna ve bir an evvel diye de bir etki faktörünü eklemek istiyorum. Bunun için de sublingual uygulama şeklinin hastanın cebinde taşınabilmesi, acil servislerde, prehospital ambulanslarda bulundurulması, bir an evvel kullanılabilmeye başlaması açısından bir artı değer olduğunun altını çizmek istiyorum. Bu sublingual tabletlerin burada kullanım dozunu görüyorsunuz bu hastalarda. Bu iki çalışmada yani özellikle hem prehospital hem de acil servislerde yüksek dozun diğer farmakolojik ajanlara bir üstünlüğü var mı? Yani zaten belirgin, kendisini ispatlamış bir tedavidir nitrogliserin kalp yetmezliğinde, ama yüksek dozun acaba burada ekstra bir etkinliği var mı? Bunu vurgulayan makaleler. Evet, peki aort diseksiyonu ve anevrizması yine mayor kardiyaklarımızdan, korkulu kardiyak hadiselerimizden bir tanesi acil servis için. Biliyorsunuz tipik olarak tip A asenden ve tip B desenden diseksiyonlar başlıca diseksiyon tiplerimiz. Tip A tamamen cerrahi bir diseksiyon tipi ama tip B'de başlangıçta süreç medikal olarak yönetilebilir. İşte bu medikal tedavi hasarlı aort duvarındaki kan basıncını